gas worksheet we're gonna do together, and you're gonna fill it out while we're talking about it, and then I let you use that on your test.
Okay.
So you can put as much on it, well, not as much on it, but you need to put 2 words on it or you can put what I say. But you're not gonna fill other words. Okay, so there's your pretty little liver. Can you live without a liver? No, you can't live without a liver. And there it sits. Right there, little liver. Has a lot of functions. It is your workhorse. Everything you eat goes to your liver. Everything you drink goes to your liver. Every medication you take goes to your liver. Plus your liver makes its own stuff. So again, metabolic and storage and excretory means it does great stuff. It's protective, circulatory, and we'll go into a bunch of these. So storage function, glycogen, which we know is fat or sugar, right? Vitamins, metals, and hormones. Which will save, but save storage. That's just a little diagram of your, you probably learned more about this in hematology, the breakdown of your erythrocytes, going to your heme, your bilirubin, and all that good stuff. But we're going to talk a little bit about this. Again, just a little diagram. So the excretory function of your liver, make bile fluid, bile acids and bile salts, bile pigment, and then taking your cholesterol. Takes your red blood cell, takes all that, converts it to bilirubin. What's the precursor? Okay, bilirubin. Principal pigment, bile derived from the breakdown of hemoglobin, comes from the green pigment bilirubin. I have that in hematology. Sound maybe a little familiar? No, yes.
Yeah.
Oh, you know it like that, isn't it? So your red blood cell breakdown takes off your iron. What does your body do with the iron? Stores it because it needs it again, right? Over in your iron. And then of course you get amino acids. It's also a byproduct. Okay. So we break down your red blood cell. Red blood cell lives for 120 days, and then your reticular endothelial system removes your red blood cells. Quality control officer takes them out of circulation. Hemoglobin is broken down into heme and globin. Okay, iron is returned back to your iron source. Heme becomes bilirubin. Okay. Your bilirubin from your red blood cell breakdown binds to albumin. Okay, albumin is the carrier protein. I'll talk about that a little bit more tomorrow. Okay, albumin transports it to the liver. The bilirubin is now called unconjugated or indirect bilirubin. So the bilirubin from your red blood cell binds to albumin. That a bilirubin-albumin complex is not water soluble. So what does that mean to you? Why is that important?
It's free floating and
It doesn't dissolve. Okay. How, if it's not dissolved in your blood, how would your kidney get rid of it? It can't, right? So if I have a buildup of this type of bilirubin, unconjugated bilirubin, it's going to stay in my tissue, correct? It's not going to become water, it's not water soluble, it's not going to flush out. So if I get a buildup of this, what does my skin turn? Yellow, because I can't flush it out. Make sense? So indirect, insoluble. Okay, the hepatocytes. The albumin is cleaved off and sent back to circulation. Albumin is a workhorse. Your body knows it needs to keep it. Okay? The bilirubin enters the hepatocyte with a conjugation with an enzyme that's that, and we'll just call it UDPGT, which converts the bilirubin to conjugated bilirubin. Takes off the albumin, the enzyme conjugates it, okay? It is now water soluble. So the liver does that, the hepatocyte. cells in the liver. Bilirubin albumin cleaves it off. Enzyme makes it water soluble. Now, once it's water soluble, what can your body do with it?
Flush it out.
Get rid of it. Exactly right. Get rid of it. So soluble bilirubin, water soluble bilirubin, is secreted from the hepatocyte, the liver cell. Okay, so that's just the flow. Cannula, the hepatic duct, gallbladders, whatever, into your intestine. Bacteria then acts on the bilirubin in your intestines, and you get urobilinogen. Talked about urobilinogen in your analysis at all yet? Okay, that's why it's always positive. It's negative, never negative. Red blood cells are always turned over, so you always have urobilinogen. Any secrets there? Understand that? In the intestine, the bacteria in the intestine takes your urobilinogen. About 80% of it goes into your feces. 20% goes back to your liver. And then moves it into urobilinogen. Urobilinogen, as it escapes to circulation, into your blood, right? Goes through your kidney. Urobilinogen, normal value, 0.1 to 0.1. Big secrets there? No? Okay, so the synthesis function of your liver makes proteins. Inside your liver, you have your protein or your body pool of amino acids. Okay? We're going to talk a little bit more about this tomorrow as far as your proteins and with SPE. But think of it as like a pool of Lego blocks. And your body has to reach into that pool and grab whatever Lego blocks it wants to make whatever protein it needs. And that's its job. Makes all proteins except immunoglobulins. Where do immunoglobulins come from?
Blood cells.
I'm sorry?
White blood cells.
White blood cells, plasmacytes, yes. Body factors, okay, converts ammonia to urea so you can urinate it out. Functions by synthesizing cholesterol, stores glucose as glycogen, breaks it down. Okay. And then the synthesis function of lipids, which we talked about in lipids. We said that your liver makes some of your lipids. Remember, some of it you eat, and some of it's from Aunt Betty, right? Some of it you get. Okay, protective function for detoxification. Okay, again, everything you eat, everything you take is going to go through your liver. Your liver's going to try to detoxify, try to get rid of it. When we start talking about therapeutic drug monitoring, if you are taking a medication, a drug to help you, and your liver is going to take it out of your body because it thinks it's a toxic substance, do you see where there's constant battle between what to take to get a therapeutic effect and what not to take so you don't get a toxic effect? So that's all about TDMs, that's all about therapeutic drug monitoring, and that's why. So we'll talk about, because of this function of your liver to detoxify, drugs have to be manufactured in such a way that enough of the drug is still viably able, your body's still able to use it once it passes the liver.
Is that why a lot of side effects on some medications is liver disease because it's overtaxing your liver? And
You got it. Yep. Can hurt your liver. Yep. Yep. Circulatory function, regulate your blood volume. Okay? Again, blood storage area. So it acts as a reservoir for blood. Nothing new there. So what do we do? Why in chemistry? That's all the what your liver does for you, yeah. So we know that we can't live without a liver. So in the laboratory, what kind of things do we do to help the physician diagnose what's wrong with your liver. Because we know we can't live without a liver, okay? We can run liver enzymes, which you can run your enzyme lecture called AST and ALT. And that will be increased if we have any kind of liver failure. If you pay attention to anything on, if you take like Lipitor or cholesterol reducing medications, and you hear that little footnote at the end that says your doctor's gonna run some liver enzyme tests just to make sure it doesn't hurt your liver. Okay, so these are what they're talking about, your AST and your ALT. Those are what's gonna be elevated if you start having liver problems. Alkaline phosphatase elevated in liver disease. Albumin is reduced. Okay. Total indirect bilirubin will be elevated, and your ammonia can be elevated. Ammonia is very neurotoxic. Ammonia in your blood will mess your brain up and you're gonna die. Okay? So again, it can be elevated. We know you have a problem with your liver if you become yellow, right? We worry about jaundice. So it can be caused from 3 different things. Prehepatic. Prehepatic means there's some kind of a disease process going on before it ever gets to your liver. Okay? So think about what happens to your body in this whole process of getting rid of your urobilinogen before it ever reaches your liver. What were the things we talked about? I'm sorry? Red blood cells, right? Did it not all start with a red blood cell? You need a red blood cell to live, yes? And we know your red blood cells live for 120 days. And then your body recycles them, right? Is that not prehepatic? That all happened before it ever got to the liver. Your red blood cells started to break down. So what are some things? Hemolytic anemias, right? Breaking down your red blood cell at a fast rate of speed before it ever gets to your liver. It's kind of like when you get, 25 inches of snow, the snow trucks can't get it out before, it just piles up. You're rupturing too much, you're getting too much at one time. Hepatic. That means there's something going on in the liver. What did we say your liver did for that whole process of producing urobilinogen so you can get rid of the bilirubin out of your body? Cleaving of the albumin, correct? Okay, the enzyme, correct? Okay, that doesn't function. You can have jaundice because your liver isn't functioning correctly. So hepatic. Post-hepatic. That was the process that happened after it left the liver. That whole process I told you about going through this duct to the bile duct to the intestines to everything else. What happens if you have a gallstone? Where is your gallbladder? Before your liver, in your liver, or after your liver?
Well, like it's
After, right? Because the bile then goes to your gallbladder. So if you have a gallstone, things are supposed to go from that duct into your intestines, right? Because then your intestines act on it to become urobilinogen. If you have a clog there, is it going to be able to go from the gallbladder to the intestine to be further worked up? No. So you're going to turn yellow. Make sense? Because of a buildup. You can't get rid of it. There's a stop in the process. Kind of like traffic, huh? Right, stop.
Now, is there another cause for like your bilirubin to be up besides your liver? Well, no, because like when my daughter was born, her bilirubin was 18. Like, so was there something wrong when she was first born, or is that something different? Oh.
That is a problem. Yeah. Okay, so prehepatic. Increased red blood cell destruction. What happened before it ever got to the liver? Okay, hemolytic anemias, AHAs and WAHAs. AHA, autoimmune hemolytic anemia, WAHAs, warm autoimmune hemolytic anemias. So autoimmune hemolytic anemia. Your body is attacking what?
Your red blood cells.
Your red blood cells, yes, yes. Can be a hereditary problem, can be a membrane abnormality, enzyme deficiency, pretty much all those things you learned about in hematology. What you're asking me about is the very last one. Hemolytic disease of the newborn fetus and newborn. Okay? Yes? Questions?
The increased red blood cell destruction, is it because the spleen is overwhelmed and sending more to the liver? Because doesn't the spleen take care of the red blood cells?
But if your red blood, and yes, but you're right, you're just getting, why do floods happen, right?
Right.
Because you get too much at one time and your
Right.
body can't clear it.
Okay.
Exactly. So in this case, you have an increased red blood cell discretion. Your spleen is normally just will pick this one and pick this one, all of a sudden,
It's overwhelmed.
they're all ruptured.
Okay.
Okay. So with hemolytic disease in newborn, and it is in a slide or later, okay? In hemolytic disease in newborn, fetus and newborn, you have fetal hemoglobin when you're in your mom's tummy. Fetal hemoglobin has a very high affinity for oxygen because that baby needs to pull that oxygen off your red blood cells before you get it. That's why you're always out of breath, okay? Once that baby's born, does it need that magnet anymore? Does it need that high affinity for oxygen? No, because it can get it out of the air now. It doesn't have to pull it off you anymore, okay? So the baby's body is trying to convert all that hemoglobin to adult hemoglobin versus fetal hemoglobin. And we're overwhelming the baby's liver.
Okay.
But there's something a little more to it with the baby's liver than with the fetus. Okay, so you see an increased unconjugated bilirubin exceeds the conjugating ability of the liver. You don't see an increase in urobilinogen in the urine. Why? It's unconjugated, it's not soluble, it's in your tissue. It's causing your eyes to be yellow, your skin to be yellow. It's staying in your tissue. Okay, hepatic jaundice causes a defect, can be a defect in the hepatocyte, defect in the liver cell itself, acute liver injury. Okay, somebody hit you. Chronic liver injury. What can cause chronic liver injury? Medication, alcohol, yes. Impaired cellular uptake, defective conjugation, something just doesn't work right. Abnormal bilirubin secretion from the liver, just some things that can happen in the liver, hepatic jaundice. Okay. Hemolytic disease in newborn will show a very slow increase levels of unconjugated bilirubin. Again, we're changing it over, okay? The immature liver does not have the enzyme. Okay? So it can't conjugate it. It can't make it water soluble. Okay? So the baby can't get rid of it. So here's the deal. When the baby is in your stomach, right now, your liver is working for that baby. Your liver is getting the bilirubin out of the baby system. Okay? Once that baby is born, your liver, you're no longer attached. And their liver is immature. Their liver can't do it. That's why you get buildup. That's why you get the increase.
Does vitamin D help break it down? I mean, they say
Sunlight?
Yeah.
Light therapy? I don't know what vitamin D does it.
I thought it was the vitamin D that they're getting out of sunlight.
She had a belly blanket.
It has lights in it.
Yeah, wrapped it around her middle so long every day.
Yeah, we
She
call
looked like a little
we
glowworm.
call them glow babies.
Yeah, she looked
My
like a glowworm.
twins had to be in the little sunbathing incubators with the little masks on that make them look like superheroes.
Yeah.
And they're just like naked laying
Yep,
there, so
yeah,
warm.
well, sometimes they're not naked.
Well, they had a
this little-
diaper.
Yeah, well, they not even, sometimes not even a diaper, it just looks like a little G-string kind of thing. But yeah, and so with little eye protecting goggles, if you will, so they look like they're a swimmer. So, you know, back in the old days, right, the Indians had their babies out in the field and they strapped them to a papoose thing and went on and, you know, So the sunlight was right there and the babies didn't have a problem. But nowadays, what do? We bring that baby home and it's 90 degrees outside and we still wrap them up with a blanket and all you can see is a little bit of a face, okay? So when you bring your babies home, let them get air, let them breathe, okay? So put them near a window or whatever, let them get some sunlight, let it convert. So phototherapy will help.
What is it in the sunlight that's breaking it down though? I mean, that our body's not naturally producing, like even in a baby. Is it just,
That's beyond me. I just know sunlight does it.
okay.
Ultraviolet light though does it, so you're fine. Okay, so, no increase in urobilinogen, because obviously it's unconjugated, it's in their tissue, because their liver can't conjugate it, okay? And so they would have a bilirubin of about 15 to 20, which can cause kernicterus. Kernicterus is a buildup of bilirubin in the brain tissue, and it can cause mental retardation and all kinds of good stuff there, okay? So, what do we want to do? When normal bilirubin, we'll get to normal values in a minute, but I'm just kind of giving you a frame of reference. Your normal bilirubin is usually like less than 2, okay? Babies, a lot of times, what's semi-normal for a baby would be around 8 to 10, okay? When you get to that 10 to 15 range, that's when we get nervous. That's when we will probably do some phototherapy. Okay, again, let them, you know, put them near a window, let them get some sunlight. And then the glow baby thing, right? You put the lights around them. After 20, you're talking, and this is really more of a blood bank thing than a chemistry thing, but when it gets closer to 20, we're going to start doing an exchange transfusion. We're gonna start taking that baby's blood and putting in fresh blood. Taking that baby's blood and putting in fresh blood. It's just not clearing fast enough. Okay. And again, that's a more of a blood bank thing than it is a chemistry.
Yeah, hers was 18.
So she was getting up there. I'm sure they were getting nervous.
They didn't tell me, but of course they didn't want me to be nervous.
Yeah, yeah. Some of it has to do with blood types. You know, if your blood type's different than your baby's blood
It
type.
is. Hers is B negative and I'm A positive. Don't ask me
Yeah. Oh,
how
you
that
guys,
happened.
yeah, you're.
Her dad's, don't ask me how she is. I need to test her blood when you get the blood bank because something's off.
Yeah, no kidding. Okay, so anyway, yeah.
Yeah,
That
yeah.
makes sense. Yeah. So we do heel sticks on babies, okay, and we do their bilirubin, and that's why we want to make sure that the bilirubin doesn't get too high because they don't want like brain damage from the baby. And again, exchange transfusion, which again is not chemistry, that's blood based. So, if I gave you a value of a bilirubin, are you going to be able to let me know at what point, so what's normal? Can you tell what- approximately for a baby. So 8 to 10, we're just gonna be careful. What are we gonna do between 10 and 15?
Get worm.
Phototherapy. And then 15 to 20 will help impact exchange transfusion. That's kind of just one of those thought questions I throw at you at the test. And why? Why is the baby having problems? What is the main answer for that one? It doesn't have the enzyme to make it unconjugated. You got it. Exactly right. Exactly right. The baby's liver is immature and can't conjugate. Yep, you got it. Post-hepatic. So this is after the liver. Bile obstruction, again, gallstones, possibly tumors. Lap findings, we're gonna see an increase in your total and direct bilirubin. Decreased urobilinogen. So it's not getting to the urine, right? It's not getting there. Clay-colored stool. Your urobilinogen, 80% of it goes in your feces, correct? It's what turns your feces brown. So if the bilirubin is not getting to that process, does it make sense that your feces aren't gonna be their normal brown color? Yes, you're gonna look clay color. And when I say clay colored, I'm not talking terracotta, I'm talking like cement gray color, clay color, okay? So your liver enzymes, your ALK phos, your ALT, your ASTs, those are gonna be increased. Gonna Defective conjugation, again, newborns, they don't have the enzyme. Just repeating what I already said. They have an immature liver. There's a disease there, so if anyone wants to do that as their disease state, they can look that one up. Type 1, you have no conjugation, and that's fatal. Type 2, again, is that enzyme deficiency. Increased total bilirubin can cause severe jaundice. People are doing not only yellow, but they're almost orange. And then a decrease in direct bilirubin. Items in there. Hepatic disorders, liver inflammation, and hepatocellular damage. Hepatitis, viral hepatitis, that you're gonna get in serology. So I don't deal with the hepatitises, okay? Just know that hepatitis can cause an increase in your jaundice. Cirrhosis, scar tissue. Tumors, Rye syndrome. Rye syndrome is a condition where affects children if they take aspirin with a viral. So if they have a viral cold, virus cold, and you give them aspirin to help them make them feel better, it can cause Rye syndrome. Okay. We'll probably talk. I know we'll talk more about Rye syndrome when we talk about TDMs, aspirin, and then of course drugs and alcohol also cause hepatic. Specimen collection, specimen requirements. Okay, we can use either serum plasma, urine, or spinal fluid. You need to protect it from light and heat. So when you draw baby bilirubins, we have some tubes in there, they're amber colored. They're not the clear, white, clear plastic, whatever, they're amber colored, protected from light. Have you ever seen a vacutainer tube that's amber in color? No. So how do we protect a tube from light? You actually have to wrap it in aluminum foil. So in your processing department, they should have a roll of aluminum foil, and they would wrap it in aluminum foil.
The micro tubes, those are blue.
They're
The
what?
micro containers, they're either blue or cloudy or white.
They can be the clear, well, not clear, but they're that plastic, white plastic, or we can have the amber colored ones. And I have some, I can show you. Hemolysis can falsely decrease a bilirubin in some methods. You would think hemolysis would increase things, but for some methods, hemolysis will actually decrease it, falsely decrease it. So here's one where hemolysis was not your friend. Well, hemolysis is never your friend. And that's a big thing with your enzyme worksheet too, and I ask you, does hemolysis increase or decrease? And that's the big thing there. Okay, so again, protecting from light and heat. So a lot of the refrigerators that we store our blood in have glass doors and the light that pretty much stays on all the time. So does it help our bilirubin status at all? So if we drew blood on a patient today, and 2 days from now, doctor calls down and says, hey, let's do some bilirubin studies on that patient. Do we want to use that specimen? No, we want to get a fresh specimen because it can break it. So here's your normal values. Total bilirubin conjugated and unconjugated, 0.2 to 1.0. Direct bilirubin conjugated, 0.2. Neonate bilirubin can be 1.0 to 1.0, which is a really broad range. So again, 8 to 10, 8 to 12. Pretty much normal. Anything over 12 to 15, let's put them in the light. Anything over 15, we're gonna worry. So we have 2 tests that we do in the laboratory. We do either the Gendrastic Golf one, uses caffeine as an accelerator. And then we have the Evelyn Malloy Boy Evelyn, which uses methanol as an accelerator. So those are the 2 methods that we can measure our bilirubin in the lab. And it'll depend, it's kind of like, neither one of them is necessarily a reference method. Again, this was your short one. The other This should look very familiar to you. Okay, so this is just a requirement that Jean likes you to have. I probably did it with you as a freshman, didn't I? Yeah, just in one of your very first year. So again, it's an annual requirement. Here you go, one more time. In your job as a lab tech, you are going to have the possibility of an exposure to blood and body fluid. Okay, it's nature of the beast. Okay, so every year you have to go through bloodborne pathogen training. It is a CAP requirement, OSHA requirement, so that we remind you that your job title means that you could have a possible exposure to blood and body fluid. Okay, how that whole thing came about is we started out with universal precautions. Back in the day when I was a young tech, okay, somebody came into the lab that had hepatitis. Their tube had 50 million stickers on it going hepatitis, and it was on double bagged, and people had 6 gloves on, and they carried it in the corner like the hepatitis was going to jump out of the tube and get them, okay? And so that's how it was actually when I first started. And then we went to universal precautions. I graduated in '84, so you can see it was right about the time I graduated, okay? Where we said, okay, this is silly. This patient we know has hepatitis, but what about the patient that's not diagnosed yet, right? So we have to treat all the specimens as if they're potentially hepatitis, some kind of bloodborne pathogen, okay? Then we went to body substance isolation, which kind of threw in all those body fluids, not just blood, but how about all those other body fluids? Remember we talked about last week, we say your body excretes it, we test it in the laboratory, so what about all that? And then finally they got smart and said, okay, this is crazy. Let's just say, if it ain't yours, don't touch it. Anything that's not yours has the potential to be a hazard to you. Okay? Unfortunately, in our field, we get exposed more than the average bear. Okay? So universal, standard precaution. I think if they could look back on it now, that I think universal precautions would have really actually been a better answer for standard precautions, because universal over everything, but of course we kind of didn't know that at the time. Potentially infectious material, so again, anything, even, there is this magical thing that happens in the laboratory. When you donate a unit of blood, okay, before we test it is a biohazard. We test your blood, okay, for everything that can ail you, and all of a sudden it then becomes a food product and it's no longer a biohazard. However, if you had that bag of blood in the laboratory and that bag broke open, you would treat it as a potential hazard cleanup, all right? But that bag of blood leaves the laboratory to be infused into a person, it's magically uncontaminated again. So there's that magical thing that happens from being icky to being okay to, so magical thing that happens. Other potential infectious material, again, body fluids, tears and saliva and semen and vaginal secretions. Other unfixed tissues. So when histology gets that toe in the department, okay, it's a biohazard. But as soon as they fix it with either formalin or whatever they fix it with, it is no longer a biohazard. Because supposedly whatever that fixes it with kills whatever's going to ail you. Okay? Some factors that can affect it is exposures. What is in your population? Or do you understand that? I mean, if you're working in an HIV clinic, do you not realize that your potential for being exposed is much higher than, say, somebody who's working in, a pediatric clinic? Okay, so that just makes sense. And then the bottom, a single drop of infectious blood can cause a sufficient, is enough for a sufficient hazard. That was one of the things I had to get through to them this year, because people were arguing with me, not arguing, they had the question of how much blood does it take? Okay, well, technically they say it's a drop of blood. It's not that you have to be splashed like Carrie with this whole gallon of blood, right? I mean, it just means a single drop. And the other thing too, and we've gone back and forth year after year after year. How about my computer station? How about my telephone? If I am in a biohazard area and I'm popping corks and I'm getting serum on my hands, and the phone rings and I pick up the phone. And then Patricia just comes in from lunch. She hasn't had foot gloves on yet, but the phone rings, so she picks it up. So she's exposed herself, correct? So we went through, the phones and the computers are not, they're clean areas, so you have to take your gloves off, to, well, there's no way you can, you know, some people do and some people don't. So now, right now, we are back to anything in a biohazard area is considered biohazard. Your telephones, your computers, your countertops, everything. See how it goes. It's just a list of some biohazard, bloodborne pathogens. Hepatitis C, malaria, syphilis, babesiosis, or whatever, brucellosis, Creutzfeldt-Jakob, that's mad cow, and then viral hemorrhagic fever, that's Ebola. Because we're not allowed to say Ebola anymore, 'cause that's pretty simple. Viral hemorrhagic. Last year Ebola was a big disease, a big problem. It's not gone away, but it is significantly reduced. I mean, Ebola has been around forever, and so, but it is significantly reduced. So if for some reason it should flare up again, we'll just do whatever the CDC tells us to do. With the Ebola outbreak, we did learn a lot this time. Even though we've had Ebola, I mean, I remember living through an Ebola outbreak when I was a teenager. But this was the first time that it actually came into this country. And what we learned, the CDC actually had a vaccine for Ebola 10 years ago. But they wouldn't, nobody over there would test it. Nobody over there would allow it, okay? So it went untested. So what happened this time is we brought our people back, right? Everybody had their pennies in a wad. It's, oh my God, they're bringing Ebola in this country. They brought that doctor back who was on death's door. He was just more dead than alive. And they're like, do you want to try it? And he's like, yeah, okay. Within 3 days, he was eating, showering, and taking care of himself. Okay, so that's what we learned. So then they used his blood to actually make a better vaccine because he'd already been exposed. Okay. So in March of last year, March of 2015, Sierra Leone, which is a Providence or whatever over there, again, they were one of the hardest hit. They finally said, okay, we'll take the vaccine, we'll try it. And actually it was very successful. Very, very successful. And so that was one of the big things. So this is just Barb talking, and I probably don't know the truth, but my guess is within the next 10 years, when you get a flu shot, Ebola is going to be in it. My guess. Just an educated guess. Never come up with Zika, that's going to be in there too. Right now we don't have a Zika. Yeah. Okay. That's So the three main bloodborne pathogens that OSHA still wants us to address, CDC and OSHA: hepatitis B, HIV, and hepatitis C. Hepatitis B, we know you have probably had a vaccine against, correct? Okay. And then when you go to your job and you tell them you've had that hepatitis B, they're going to probably draw a titer and just make sure you're still immune, okay? Hepatitis B, for some, like very small percentage of the population, things like 0.3%, the immunization doesn't work, and they never did do seroconvert to be protected. HIV, we have nothing yet. Hepatitis C, we don't have a vaccine against hepatitis C. However, they have a treatment that's proved now to cure some forms of hepatitis C. So that's encouraging. That's really encouraging.
To cure or to put it into
To
remission?
cure. They say to cure. Whether it's just to put it in remission, we'll just probably have to take a little more time on. Right now, they're saying they're curing it. So we'll see. So just some symptoms comparison if they do that. So again, hepatitis B. Again, if you're employed, the employer has to give it to you free of charge. That's required. Modes of transmission, again, mucous membranes, broken skin. So if you had a splash on unbroken skin, that's your plastic bubble, you're perfectly okay. You always wanna watch out for sharps, never wanna pick up any broken glass or anything with your hands. And again, indirect contact, so again, your countertops, your counters, your telephone is a possible mode of transmission. That's not sexually, not work related. So how do we protect you? We have to provide personal protective equipment. We provide it, it's a work practice control that you wear it, okay? So again, we have a lab coat you can wear. We launder them, we don't have you take them home. Disposable gloves, and again, you don't wash and reuse them, you just take them off and throw them away. And again, you have safety glasses and goggles.
And then what floors are we gonna be providing our own, or is something?
No, it's against law, which says you cannot require people to provide their own PPE. Now, I will say this though, safety glass, of somebody who wears prescription glasses, and then you have to put safety glasses over the top of that, they have shown that that does obscure your vision, okay? Sometimes it's not that easy to see. So there are people who will purchase their own prescription safety glasses, okay? There are some companies that will actually purchase prescription safety glasses for people as well. That is not an OSHA requirement, but again, depending upon what you'd like to do. Now, as far as back in the day, because it has to have safety side shields, because not only can you get splashed this way, it can come in on the side too. So you have to have side shields. So 10 years ago, we were allowed to use little plastic side shields, okay, that you would just put on your regular glasses. That your glasses would be your safety glass, then you put on plastic side shields. And then 3 or 4 years ago, they said, no, that's not good enough, that went away, okay? And then last year, they came back and said, okay. So now the side shields are acceptable again. So being the safety officer, I did the research and I found a company that would provide them, and they really only cost $5 a pair. So I got free samples so that people could look at them, but my employer would not pay for them. And so I offered them up to employees and said, hey, if you want these, I can order you them, but it's gonna cost you $5 a pair. And so far, everybody said, oh, yeah, and then nobody's ever come up with $5. So, again, whatever you do. So I have freebies, free samples. Gloves, any questions on gloves? You guys know about gloves, right? Glove removal, questions on glove removal?
So I've got a question.
Sure.
If you're considering your desk and your work area biohazard, should you just wear gloves when you're still typing and stuff?
You should, in all honesty, the minute you walk in the door, the first thing you should do is put on gloves.
Okay.
And then the last thing you should do when you're ready to walk out is take your gloves
Take
off,
your
wash
gloves
your hands and go. And
Okay.
not touch anything.
But you should still switch gloves though, even
You
if
should
you're-
always
yeah.
switch gloves. Yeah, whenever they're discolored or the
Mhm.
hands are sweaty or,
Even
yes,
if
or they
you've
get
got something on
contaminated.
them. Yeah.
Yes,
Okay.
yes, but technically, that's what you should do. You put them in the minute you walk in before you touch anything
I'm
and
cool
not
with
take
it.
them off until, yes,
Is there a protocol to switch between patients?
always, yes,
Just
you
their
have to.
specimens though, not the actual patient.
No, the actual person, but not the specimen.
Okay.
Oh my God, you'd be changing them like, oh geez, every 2 seconds. No,
Okay.
no, especially if you're in chemistry. You go through easy 100 specimens in morning run,
But you do have
just
to,
in morning run.
you do have to change them if you're switching patients though, right?
Patients, yes.
Okay.
Yes. Lab coats, the only thing I really want to say about lab coats, there are 3 different types of lab coats. You have clean lab coats, in-use lab coat, and dirty lab coat. Okay. So your clean lab coats, obviously, for us, we keep them in those bins so they're separate from the in-use. The in-use are the ones that you hang up because you used them yesterday, but you can use them again tomorrow. And then, of course, dirty lab coats, you would give to G&I, and we would put them in a bag, say dirty, and then we'd have them laundered. It is important to know that your in-use lab coat, okay, should not go to a patient area. I had to really fight with this one because our blood bank people have to take their units of blood for like surgery and things like that, and they wanted to just grab the unit of blood and go. Well, you can't do that. So you either had to stop and put on a clean lab coat, or just take your lab coat off completely. Again, there's that magical thing that happens to that unit of blood once it walks out of the room, right? it's no longer biohazard, so you're not required to wear gloves or lab coat or anything, because it's not a biohazard when that magical thing happens. So just take your lab coat off and take the Also with our histology department, they go to the rooms and do bone marrow aspirations, and they're dealing with blood and bone marrow, right? But they're also dealing with their stains and things like that, so they always wanted to wear their lab coats. And some of them lab coats, actually the head of the hospital called and said, "What are you doing?" I said, "Okay, guys, you gotta change out." So now they keep like a clean one every course. Again, not clean in use, but clean one. Putting it on, taking off. Face protection. You got some goggles. Order removal, again, you want to take off your gloves and then your face protection if it's not visible. Work practice controls. This is a manner in which a task is performed. You have control over your work practice controls. You can either do it or you don't do it, right? So hand washing. Am I gonna stand there and tell you wash your hands when you get out of the bathroom? No, I'm not gonna be in everybody's bathroom telling you to say, wash your hands. You do know that 83% of the people will tell you that they wash their hands after they go to the bathroom, but in actuality, only 62% do. Yes. So anyway, thoroughly clean your hands with soap and water, whatever, after glove removal and all that good stuff. Hand washing. Alcohol, hand rub, no questions. If you are dealing with a specimen with C. diff, Clostridium difficile, you must use soap and water. Because the C. diff is an encapsulated bacteria. It has a little capsule around it, but it protects it against the alcohol. So you have to use soap and water to actually wash it off. And you do not want C. diff. You do not want C. Worst diarrhea you've ever had in your life. So that's how to do that. So again, we do a break, we don't bend or recap needles. The only recapping we allow is the one-handed scoop. Does Jean talk to you about that at all? Okay, so it's just a one-handed scoop. Dispose from a sharps container. You don't eat, drink, apply cosmetics or lip balm, handle contact lenses in the work area. We did have an employee at the CAP inspection who was chewing gum, and so that was a problem. No food or drink is kept in refrigerators. It's very easy to do. Sometimes when you have a big party in your refrigerator and the break room gets a little full, sometimes it will overflow into the storage room refrigerator, and that is a big no-no. No mouth pipetting, which you guys know, for your PPE, for the tasks that you're performing, and cleanup spills. Question?
So you said that like wearing PPE is based on the employees. So why would it fall on the lab itself when she was chewing gum? Wouldn't that be on her?
Well, and that's the battle I get to face when I go to work on Thursday, because I have a policy that says you don't chew gum. She did the bloodborne pathogen test that said I will not chew gum. OSHA says if you have a willful violation, the fine actually doubles. Because she was chewing gum in the presence of a supervisor who should have told her not to. I don't know where I'm going with this. So, yeah. So we will see.
You don't really have a choice.
No, you don't.
Like,
So
it's
you
your
just
choice to wear
use
goggles, but not really, because
Absolutely.
you need to.
But again,
Kind of like a seatbelt.
it is.
How it's your choice,
Exactly.
but not really.
Exactly.
You're gonna pay the fine.
Exactly.
So would you would
So-
be fined for it too then if she wasn't wearing gloves?
Correct.
Even though that's her.
Correct. Correct. Or safety glasses or lab coat. Correct. No different. No
And that's
different.
falling back on an equal opportunity out there, right? Because, the company has to provide that person with the equipment they need to continue to be safe. Well,
Now,
it's
technically, if
provided,
you don't wear your
but-
PPE, I could fire you. You know, I do an inspection and I walk up and, now I'm not a mean safety officer and that, when I'm doing an inspection, I usually tell them I'm inspecting and if you're not wearing your lab coat, I'll say, hey, you got your lab coat handy? And, usually you would get up and go get it and put it on. If I come back and you still don't have your lab coat on, I'll say, hey, we're get a chance to get that lab coat. And then if I come back a third time, which I will, and you don't have your lab coat on, then it goes in my report. And so far I've forced it fire. That's what we call it.
What about face masks? We never use them in the lab, or is that an optional thing?
So what you're going to have when you get to your laboratory, okay, is a PPE by task form that should be posted around the laboratory. So if your job that day is to do your analysis, we have determined what personal protective you need to perform that job. And if a face shield is not required, then it does not say that on that shield. If your job for the day is to gross out placentas and the chance for a splatter could happen, your PPE by task would say you have to wear a face shield.
Okay.
Does that make sense?
Yes, but is it going to be available for people who, like, say I'm sick right now?
Right.
So I wouldn't want even the slightest possibility. I would want to wear a face mask for every test that I wore or did.
But now, are you wearing a face mask because, so you have to realize, we're not worried about you catching anything like a cold from a person who's sneezing next to you. Okay, we're worried about bloodborne pathogens. So if you think that you're gonna have an exposure to a bloodborne pathogen and you want a face shield, yes, we have face shields available.
But it would be something that you would normally have to ask for, not that's all automatically provided throughout the.
Correct.
Okay.
Unless it is on that PPE by task list.
But it would still be provided by the company, not
Yes,
out of pocket.
yes.
So you're kind of talking about like if you had or if I had a cold and I was sitting next to you, you wouldn't wear a mask. I wouldn't give that cold to you, kind of thing. Is that what it is?
Because that's not a bloodborne pathogen.
Yeah.
That's
No.
an airborne pathogen, and that's different.
At work, if I'm sick like this, even with, I know it's just sinus congestion and stuff, I want to wear a mask just to be on the safe side that my immune system's already compromised.
You're talking about like
honestly.
the mask, like for
But I
flu
don't
or like
wear-
doctor's office where it just covers your
Yeah,
mouth and
right.
nose, not the.
These
Exactly.
are face
Yeah.
shields.
Yeah, I'm not talking
Now-
about a face shield, I'm just talking about a mask that'll go across your face. That way, my immune system's already compromised. I don't know what else I could be picking up, or what I could be giving to other people, or contaminating my own
And
specimen.
in all honesty, if you've been in a hospital lately, the minute you walk in that front door, there's a little
Yeah.
little thing that has hand sanitizer and face mask, and it tells you if you have a cold, a cough, a sneeze, or whatever, please apply a face mask.
Okay.
So that's a hospital thing, not necessarily just a laboratory thing.
What's in the flu shot this year?
It's a quadrivalent. Oh, I just had this meeting last week. It is a quadrivalent this year. And they were rattling it off. It's like H1N1, bird flu, swine flu. I don't remember. I didn't take notes. It was just a lot of H1N1, Z2, 6, 5, whatever it is. I do know it's quadrivalent though this year. I do know. And the CDC is now, or the, CDC is now allowing the nasal, the live virus anymore.
They're
Yeah.
not allowing it?
They're not allowing it this year.
I don't like those.
Yeah, a lot of people didn't. And I think really that they only did it because they didn't have enough of the other. But this year, they're not allowing it.
How come? Do you know? Or
I don't think it, what happened last year, I don't know if you knew this or not. The CDC determines when hospitals need to start administering flu shots, when they're going to start having it out there for people to give, Walgreens and whatever. Last year, they jumped the gun and threw it out there too soon. So and the flu season just went on and on and on.
yeah.
And so what they found were people were getting the flu in March, April, and May that had a flu shot in October.
Gotcha.
That it didn't hold up long enough because they jumped the gun. So this year, they're going to hold off a couple weeks. So if you got it last year in August, that won't be available this year. I heard it's not gonna be available until like the first part of October, which is kind of, because you were asking me that question.
So I have an appointment on the 2nd to get my flu shot at my doctor's office. Is this not going to be a valid?
2nd of September?
Yeah.
I don't know.
Oh, yes.
Because I mean, we have to have our flu shot before October.
Right before October, right?
Is
Well,
it before October? I thought we were supposed to get it
In
as
October.
soon as October.
Like in October, right
Yeah.
before we start clinicals.
Because I don't know that they're gonna be available before,
Are you
according to my
going
meeting, yes, last Thursday,
Walgreens anytime, it's not
with
like.
the Environment of Care. So I don't know if your doctor's office has some in that they can get it early, I don't know. But,
Or is it possibly an old batch? I mean, if the CDC is requiring a certain time frame for it to be released, and he's already got it, is it not valid? Or
I
is he
don't know,
using
I
old
don't know what he's
stuff?
got, I have no clue.
Should I look at the expiration date before they?
Well, and they are, and you actually have to have that on the form, because I think they'll give you a form, you actually have to have that to take to your clinical site anyway. And it has to say what the lot number and all that stuff is, expiration date and all that stuff is too. I don't know. I'm just saying, on Thursday, we had the meeting with the infection control nurse and everybody else, and it was reported that the CDC says not to give it as early this year as we did last year. Yeah.
And it's okay to get a flu shot while pregnant, right? I didn't get one when I was pregnant with my daughter.
The shot, not the live virus.
Okay.
Yes.
'Cause I know I didn't get it 9 years ago because I didn't care. Now I have
And then
to.
again, I heard that the CDC is not saying not the live virus this year. Yeah, so that'd be interesting. You have to come back and tell us what you not get it.
So is a live virus more effective than when you just get the shot?
Apparently not.
Okay.
Apparently not. For some people, their immune system didn't act the same as with the live viruses.
Gotcha.
Yeah, so they said it wasn't as effective.
But some
And they found that people over the age of 65 were the ones that were the most affected by getting the flu later, that it didn't hold its effectiveness to the end.
I gotcha.
Yeah, that's what they found out. Spill cleanup, any questions on the spill? I think Dean kind of down that too. Disinfectant and all that good stuff. Engineering controls, close and lock centrifuge lids. I know our centrifuges in here are a zillion years old and a lot of them don't lock. I think I have one centrifuge that will actually lock and not let you open it until it's done. When you get into the real lab, more and more of them do. This was new with OSHA this year. If breakage occurs in a centrifuge, the lid must remain closed for 10 minutes after the centrifuge is stopped. So again, this was new this year, because of aerosols. So if it's spinning at a high rate of speed and it breaks, you got little teeny droplets that are still in the air when you open that lid. Yes.
How do you know if breakage has occurred until
You
you open
will
it?
hear it. Have you
Okay.
guys not heard a centrifuge where something breaks or, yeah, you will hear
I
it.
seen actually it was broke all up in the centrifuge, so we had to clean it out.
Do they leave it closed for 10 minutes first?
I don't think so.
So I actually got a label maker and made little labels that said, must be kept
I
closed.
don't think so.
Yeah.
She just instantly started cleaning.
Yeah,
My neighbor said you should put it in the fume hood.
the centrifuge in the fume hood, that's an option. It's not required, it's an
Yeah.
option. Yeah, anyway. And then of course we have the benchtop shields. So with your question about having a mask, you can always go behind the benchtop shield too. And they're all over the place too. That's right, just to see. Okay. Engineering controls, waste disposal. This is a biggie too. You guys know what goes in your sharps containers on your desk. You know what goes in your biohazard waste container on your desk. All that good stuff. Recycling, shredding. Post-exposure evaluation follow-up. Washing a needle stick or cut, flush your nose or mouth with the eye wash thingy. And you need to report everything to the instructor or the coordinator immediately. Follow the protocol. Here at the college, we throw it back on you. If you were exposed or anything like that, and we would send you to your emergency room, and it would be your insurance that takes over. The college doesn't cover any of that. When you are exposed as an employee, then workman's comp covers everything.
What if we're in our clinicals? Is that
It's the
still
same
count
as the
our-
college.
Okay.
Same as college. And those are your references. Any questions?
We get 3 shots for hepatitis, right?
Hepatitis
Hep
B is
vaccine.
a 3-shot
It's a
injection.
Oh, 3 shots, okay, I'm sorry. I don't know why hepatitis is totally like, yeah, because in their class here.
It's not the reality.